what I'll try and do in the next about half an hour's time is give you some insights as to how, what kind of cancers we have in India, how have the government tackled them, and what are the problems that we face. I would try and compare or contrast things that are happening in India with what's happening in the United States occasionally, and maybe try and find some areas where collaboration could be fostered. So I have divided my talk into 4 parts. The strengths of what we have in India, what are the weaknesses that we have, the SWOT analysis we must lead on. So let's look at the strengths. Anil did mention when they entered Tata Hospital, they found huge number of individuals. So Tata Hospital typically sees about 50,000 new cancer patients annually, and approximately 450,000 come for follow-up visits annually. There are some cancers that are shared with the United States. We have, when I look at the qualitative nature of this problem, I see lung cancer, I see breast cancer, which is common on both sides. And I also find that there are some cancers that are uniquely very low in our country, and lung cancer is not a very common cancer compared to what we have here. Prostate is another cancer, colon is another cancer that we don't have in India. As against that, there are some cancers which are uniquely present in India. That's one of them is esophageal cancer, the other is gallbladder cancer, and third is nasopharyngeal cancer. So each of these cancers are uniquely there in India. They're not there in so much in this country. So when it comes to numbers, there are some positive points, there are not so good points either. Although the number of patients that we see are large, cancer as a problem is not a very big problem at all. When I say big, if I were to reduce that to 100,000 population, there are 2 or 3 things which are important. One is that for the last 15 years, the incidence of all cancers put together has been a straight line. It has not increased at all, whether it is for men or whether it is for women. And over a period of 15 years, there has been addition of at least 15 years in the longevity of life over the last 15 years. So in spite of 15 years added to the life expectancy of the general population, we find that all cancers put together has not changed much. And that is because if you look at what happens in males, the rise in lung cancer is matched by a corresponding reduction in stomach and penile cancers in male, and in women it's rising breast and ovarian cancer, as it is seen in all the developed world, is offset by a matched reduction in cervical cancer. Cervical cancer has reduced approximately 15% relative reduction every year for the last 5 years. There is no screening, there is no vaccine, there is nothing that is happening that is intended to reduce cervical cancer, but it is on the wane. And if this trend continues, I'm sure another decade and cervical cancer may not be looked upon as a major problem at all. We will get into why and how these things are happening. But when I said that the lung cancer is on the rise, a decade ago, the urban statistics were same as rural statistics with 2 or 3 per 100,000. Now, if you look at those numbers, the United States numbers are around 70 or so, but in the last decade, the numbers have doubled in cities. From 3, it has gone to 6. So if I were to use some statistical terms, it would be a 100% increase in the incidence of lung cancer. But in absolute terms, it is 6 per 100,000 compared to 69 per 100,000 in United States. Whereas all cancers put together, it's less than 50 in rural India, less than 100 in urban India, and US would have 3 times those numbers. So I would repeat again what I had mentioned earlier, that overall, if you see that the incidence of lung, prostate and colon cancer is extremely low. And if I were to give an example of two of our outposts, one in the interior of Maharashtra, the state where Mumbai is, and another again in the interior of Maharashtra in Derwan and Barshi. These are two outposts. In these two areas, the incidence is almost, we are looking at a population of about 1 million in each of these places, and we barely treat about 4 or 5 prostate cancers in a year. So there the incidence is even smaller, that is, it is at places it is less than 1 per 100,000 individuals per annum. So for reasons, one might say that have they gone unnoticed, but at least in Barshi, every individual household is visited once a year to find out what has happened, what cancers have been diagnosed, has anybody died, if somebody has died, what is the likely cause, and the verbal autopsy, which is performed on an epidemiological basis, has been standardized over a period of time to get the correct, if at all, closest to the correct diagnosis by which the patient might have suffered or died of that disease. But there isn't much of cancer. And although I must say that the last census of 2011 had a life expectancy of a common Indian to be 68, if I were to look at individuals who have reached across their age of 5, the same 68 increases to about 76. So all that number is pulled down because of the first 5 years of mortality. So age-specific rate, age-standardized rates are also quite different in India compared to the United States. So the first column, age-wise, breast cancer, and you will find that on an average it is anytime 3 to 4 times the United States numbers. And one of the reasons, as I see, that they are so high must be because of reproductive life, changes in the lifestyle, obesity. There are so many other aspects, but one more reason is screening that's happening in this country on a regular basis. And we do know that the moment screening starts, there is an increase in the incidence of that cancer. That also explains why prostate cancer is high. That also explains to some extent lung cancer is higher in this country. And colon cancer undoubtedly is not so high there because of the dietetic habits. Somebody who claims to be non-vegetarian in India would probably have the non-vegetarian content of the diet, maybe one dish of non-vegetarian food twice a week or thrice a week, and he would claim himself or herself to be non-vegetarian. There are very few communities that would have breakfast that has some meat, lunch that has some meat, and dinner that has some meat. That doesn't happen. And even if it happens, you will find that out of the whole meal, it's about 10% of the food that is non-vegetarian. The rest of the vegetable matter continues to be there as a routine diet. Within that number, those numbers that I showed just now about the incidence of breast cancer, we find that there is huge variation between rural, semi-urban or urban and metropolitan areas. And that difference is clearly visible here, that there is a graded increase from 7 to 8 per 100,000 to about 33, 34 per 100,000 as annual incidence of breast cancer. What is remarkable between Barshi rural and Barshi town is that there is almost doubling of the incidence, and these two areas are separated by less than 20 kilometers. But it is only the urban habitat that there is lot more availability of food, lot less physical activity performed, and obesity is quite common in this area. But it is worth running studies that will allow us to get insights into, over and above diet and the physical activity that is performed, is there anything else genetically that may be different in this population for such a low incidence of breast cancer. Not just incidence, in general for any non-communicable disease, it is the incidence and mortality which are the two important yardsticks. And you will find that even mortality wise, we are not so bad. as far as the absolute number goes, say compared to United States. But there is again a graded increase between rural to urban population. What is troublesome is that with only 8 cancers diagnosed, 1 out of those 8 is dying in Barshi on annual basis. So much higher mortality, and the case fatality rate would be much higher when it comes to rural population. So on an average, you would see that the relative survival is quite poor in Mumbai, Chennai and Barshi versus United States, where the case fatality rate or survival would be extremely high. It would be unfortunate if, in pursuit of increasing our survival from 51 to 80%, if the incidence in India also rises to the same numbers, then we would have lost the battle. I think we need to take steps to see that the incidence does not rise. At the same time, if we are able to improve upon survival, I'm sure the mortality would be much more acceptable. So in general, the ratio between mortality and the incidence would be favorable when there is a lot more overdiagnosis. That's what happens when one screens, and it may not be so when the screening is not done at all, the way it is in either Mumbai or in Barshi. But that vertical arrow that is going up, if it can be made horizontal, that without increasing our incidence, if we are able to get a better survival, nothing like it. These are the population pyramids of United Kingdom and India. The US pyramid is almost similar, and what is surprising is that more than 85% of the population is below the age of 50. So India is young, thriving, and approximately 50%, 45 to 50% of the population is above the age of 50 in any developed world. So this is a kind of population pyramid which is no different in any of the, whether it is UK, whether it is US or any of the European countries. But if I were to look at breast cancer patients in general, approximately 65 to 70% of the patients treated in this country would be above the age of 50, and only 30-35% would be below the age of 50. As against that, in my clinic or in India, it would be 50%. Half of them are below the age of 50 and half of them are above the age of 50. Although I must say that it should be understood that the 50% that is above the age of 50 is contributed by only 13 to 14% of the population, as against the rest of the 50%, which is contributed by 85% of the population. So incidence wise, below 50 incidence is extremely low, and whatever increase in incidence that has happened over a period of years, it has happened in women above the age of 50. So we are trying to see if we can downstage this disease without increasing incidence, and there is a large randomized study, population based, that's happening in Mumbai. We have 150,000 individuals. Half of them are screened by physical examination for breast cancer and by visual inspection of cervix. As against that, the other 75,000 has had only awareness of both these cancers. And these are the figures of downstaging by these simple, low technology interventions, which are easily possible to be distributed, to be provided to the population by healthcare workers who are trained to perform this procedure for a period of about 3 months, and their efficacy is tested subsequently by a gynecologist who sees 20% of the population that they have screened. So we finished 4 rounds of screening, each arm having 75,000, and that's the downstaging, which is statistically significant for cervix as well as breast cancer, which is a prerequisite for any screening trial, that unless there is downstaging, one cannot look at possible reduction in mortality. The flip side, as I mentioned just now, 4 rounds of screening has finished about 8 years of time. At the end of 8 years, there is approximately 40% excess cancer in the screened arm. So there is an excess cancer that is diagnosed on screened arm, and that has remained 40% excess till 8th year of follow-up. So it must be understood primarily that any screening procedure which has greater precision is likely to increase incidence. And it remains to be seen how long will it take for both those to come together. There are many screening studies wherein they haven't come together for up to about 15 years of follow. So that would mean that a lot more individuals will live with a diagnosis of cancer, where in reality on the other side they would live as normal life without being diagnosed with cancer. So although the same number, if I were to use pap smear or if I were to use mammographic screening, that same 40% would rise to anywhere up to about 75% increase in the incidence versus only available. The high incidence of oral, hypopharyngeal, esophageal cancer is essentially because, I put that under strength because this constitutes approximately 55% of all the cancers and it is immensely preventable. Majority of the first 3-4 cancers are related to tobacco and the last two some infections, Helicobacter pylori as well as HPV. All of them are preventable, and uterine cervical cancer is on the wane, as I mentioned. Over the period of last 5 years, there has been absolute terms 50% relative reduction in the incidence of cervical cancer. It has been attributed to improved hygiene. It has been attributed to use of contraception. Barrier contraception is known to reduce cervical cancer by about 45%. Intrauterine contraceptive devices are known to reduce incidence of cervical cancer by about 40-45%. So all these are quite common in metropolitan area, and that's the reason why cervical cancer is on the wane. What is remarkable about cervical cancer in India is that this is the disease of low socioeconomic strata, and the number of Muslim population in the low socioeconomic strata is pretty high. Yet, if I were to look at the incidence of these cancers across the various religious communities, we find that in Muslims the incidence is approximately half or less than half of what any other community matched for social status. So a simple explanation would be that circumcision performed at the time of birth is one of the excellent protections against transmission of HPV or HIV viruses. The countries, Middle Eastern and Israel, are the countries where the government is never worried about cervical cancer at all. The numbers there would be anywhere up to about 2 to 3 per 100,000. So that's where we are trying to see if it is already on the wane, we target on tobacco and a lot more will reduce as far as cancer burden is concerned. The unique cancers are gallbladder and nasopharynx. These are gallbladder cancer is essentially in the region of the Gangetic belt as well as the Brahmaputra river in Assam. Along that river there is a lot more cholangiocarcinoma, and this is another unique cancer which is not there anywhere else except in Chile. Chile and India are the only countries where gallbladder cancer is, and a lot of studies that are going on at the moment to elucidate as to what are the probable causes leading to this rare but extremely fatal cancer because of late diagnosis. I would move on to some weaknesses. The weaknesses essentially are, with such a huge country, with such a huge population, implementation of effective treatment uniformly across the country is a problem. Now, to that end, the government has already made efforts to improve infrastructure, to improve human resource, and to reduce costs of the treatments that we follow. And there is a hierarchy of centers, the Regional Cancer Center, then there are medical colleges that also offer the same kind of treatment, and the Tata Memorial Hospital has floated a national cancer grid, a grid that will look at uniformity of care in the western region where Mumbai is. There is another center that is coming up in Vizag. The third center is already functional in Kolkata from House of Tatas, and the fourth one is coming in Delhi, so that we have a seamless integration of research for common cancers, as well as these focused areas might look at the cancers which are unique for those regions in India. The biggest problem that we face, whether it is epidemiological research or whether it is clinical trials, is to have a good follow-up. We sincerely hope that this Aadhaar, that is unique ID that every individual in India is likely to have, and its process is already on, would allow us a completeness of information as far as individuals go and the death records, so that without much of problems of follow-up, we will at least know whether the person is alive within as part of a trial, and that would allow us the completeness of information that is so very vital in deciding effectiveness of any intervention that we are testing. Radiotherapy equipments are also in arrears. We have only 306 radiotherapy equipments across the country, whereas the need is about 1,000. Again, the problem is slightly different. There are areas in India where sustained electricity supply may not be there, and the Department of Atomic Energy, in conjunction with BARC, the Bhabha Atomic Research Center, has produced and handed over the technology that will produce Cobalt machines at about half the cost that is available in the market. And these machines are presently commercially available, and about 25 of them have been positioned in various parts of the country so that they start delivering treatment. And the same machine has also been given to Sri Lanka as part of our effort to improve care with our neighbors to Vietnam and to Namibia. In general, we find that the human resource as well as the infrastructure is not yet there, but would be there over a period of coming decade when cancer will be adequately treated. That's the ratio of the oncologist. Over a period of last 3 years, the Medical Council of India has tripled the take of students, which has allowed us to increase the human resource related to management of cancer. And I'm sure by the time we go to the end of this decade, there will be enough individuals not only to provide service and education, but to also perform research focused to improve national results related to cancer. The good point about the physicians who are trained for oncology is that about 1,500 GCP trained individuals are available at this juncture within India to run clinical trials. Since there is so much of service burden, obviously the number of the input that goes in research is bound to be less, and you will find that the number of trials registered in clinicaltrials.gov is 64 from India as against 2342 in United States. So there is an effort to improve that, and as we have the human resource improving with more and more surgical and medical oncologists coming in, I'm sure we will have a lot more individuals who will indulge in research, and to that end, the training for research methodology is something that could be easily shared between United States and India. There are already lots of people from here who come on regular basis to India to see that the clinical research methodology as well as the research methodologies are disseminated within India, and we are able to run fair degree of research presently in metropolitan India, but to extend that to all other major cities is not happening, but it will happen over a period of time. Uniform care across India is something that is a goal that Tata Hospital, in conjunction with the Department of Health, has set itself for since year 2002. And to that end, we conduct an evidence-based management meeting every year with a focused area. This year it was head and neck cancer and Hodgkin's disease and infections and cancer. So what typically happens is, an year ahead of this meeting, so last year around the same time, the clinicians sat together, decided what are the common questions that are troubling clinicians in the clinic, and find out who are the individuals who have run trials related to these questions. These individuals are invited, they present their data, and an incisive moderator then looks at it. Is the data robust enough or the results robust enough for them to be adopted as guidelines? And if so, then they are adopted as guidelines. If the data is not adequate enough, or if the problem is not so very common, then the same data is utilized for referral guideline, And if the data is not there at all, then the same clinicians come together and formulate some clinical trials which can be run across the country so that the question can be answered within our own area. These booklets that evolve out of these deliberations are distributed free of charge to all the medical colleges as well as regional cancer centers so that there is uniformity of standards of care across the country, and they are also available free of charge for download on website of Tata Memorial Hospital. Training for individuals is the last component which is important as far as running research, and we are already in collaboration with IARC, in collaboration with NCI, are running lots of efforts to courses to see that as many individuals can get trained in clinical research and laboratory research. That's the phase 1 component of studies in India versus United States, and that is an area where we would like to focus, and if I'm sure there is help offered for phase 1 units which are about to come in at Tata Hospital, and at least these major centers on the National Cancer Grid will have phase 1 units which are entirely supported or at least equipped through the thoughts from this country through NCI. I had mentioned that there are places in India with least amount of electricity and they need Cobalt machines which are available today. We are putting in efforts to find out if some precision can be added to this the machine that is called Babatron is the Cobalt machine. The multi-leaf collimators on these machines could add precision to the delivery of care in the oral cancer as well as cervical cancer. And between oral, cervical and breast cancer, if patients are being adequately treated even with Cobalt machine, I am sure 70-75% of the individuals will get adequate treatment as part of their cancer treatment. The last important point that I would like to drive home is about devices and drugs. There are lots of devices, including implants, which are not easily available in India, and there is an effort to have collaboration with various universities in India and in United States so that we can produce custom-made prostheses, since the run-of-the-mill prostheses for replacement of hip, replacement of knee can be easily made. They are made in large numbers, but oncological resections related to bony tumors are not. They don't conform to routine resections. They are unique for every individual patient, and those kinds of prostheses need to be made available, and they can be made available very easily. As far as drugs go, India uniquely produces drugs at a very low cost of very great, excellent quality. And that's the kind of difference in the cost between USA and India. And we already have US FDA approved about 50 such locations in India that are manufacturing drugs, and lots of antibiotics that are coming here are manufactured in India. The oncology related drugs are no exception, and the cost difference is huge between what's available here versus what's available in India. That just allows easy access for even new and recent most drugs for a common man in India. So that's a strength that is presently well utilized. Although I must say that drugs which are either antibodies or the small molecules are not yet manufactured in India, and that's one area where the cost of drug is still prohibitive. And if I were to give an example of Herceptin, barely 5% of those who are eligible to get it would ever afford that kind of drug in India. The effort in general has been towards cost-effective research and some novel designs. The second most important part is that JIVA studies, genome-wide analytic studies, have not had much of success in this country. Whereas I still feel that they may have some success in India for the number of young patients who are diagnosed as absolute numbers. And it is this area that can be explored with JIVA studies in India. As far as cost-effective studies are concerned, essentially effort is to see that the same kind of effective treatment can be delivered at a much lower cost. So one of the example is sentinel node biopsy, which is very commonly done world over. It is also performed in India. But if I were to look at a radioisotope detecting probe, it would be anywhere up to about 30 to 40,000 or $50,000 is the cost of that probe. The cost of the isotope would be anywhere up to about $70 to $80 for each injection, and that will not be available to all the treating surgeons across the country. So here is a comparative analysis. We did a small axillary sampling compared to sentinel node biopsy, and you will find that the false negative, which is the most important aspect of comparing the procedure, that's the meta-analysis of the sentinel node biopsy world over, 8.4% false negative. It's about 10% in Tata Hospital, and the result of sampling is about 8.8%. So no different at all. The cost of axillary sampling is zero as far as this investment is concerned. So extremely low cost, and sampling removes approximately 4 nodes, as against sentinel node biopsy that removes about 2 or 3 nodes. So essentially, without using technology or a low cost technology being utilized, and the same kind of efficacy being implemented, so that at no stage even a person treating breast cancer in a remote area should feel that he is delivering inferior care. That's a novel design that we have looked at. I will not go into the great details, but this is a study in breast cancer which looked at giving a single injection of progesterone about 4 to 14 days prior to surgery. That's the arm. This is a trial design that was run over the last decade, and we published these results in Journal of Clinical Oncology last year. About 500 patients received this injection versus not. The cost of this injection is approximately $2, and that's the kind of result that we have. A 10% difference in disease-free survival and about 9% difference in overall survival. So 9% reduction in mortality and 10% reduction in the disease-free survival by giving a simple injection prior to surgery. So again, an example of a low-cost technology, easily implementable across the country, is the kind of focus of research. That was the editorial that accompanied this paper in Journal of Clinical Oncology in August of 2011. So much for so little. Elucidating this, we have now been able to have collaborations. The collaboration is essentially if such a simple intervention can induce such a large change as far as patient's outcome is concerned, what is it that is changing in tumor? So here we have about 50 pairs of samples collected before and after injection of progesterone. So the tumor sample collected at time 0, injection given, and then a week down the line a second tumor sample collected. We have 50 such pairs of samples which are now being explored for on next generation sequencing platform for a transcriptome study. Now obviously it is not easy to get samples out in United States. Biological samples are not easy to get, so we have wet lab in Kolkata where we would have the next generation sequencing performed for transcriptome study, and we've now involved about 3 or 4 different groups. NCI is one of them. We have another group at University of Iowa. The third group is at George Washington University, and the fourth group is in India in IIT Mumbai. We ourselves have our own bioinformatics group in Tata Hospital. So 5 or 6 groups will sit together and work on the transcriptome analysis. Primarily, the goal is that if more and more minds get engaged on this kind of a study, there are not many studies, there aren't any studies with more than 5 samples being studied for transcriptome at the moment. So for this kind of huge amount of data, we need as many people engaged as possible, so that much closer can we be to the truth that we are looking at. Also, consistency of the results if 5 or 6 groups distinctly work on these. And as I see it myself, I intend to give about 2 to 3 years for all these groups to come to the conclusion as to what's the best fit model they can make for the transition that happens with a single injection of progesterone. And at the end of it, I would like to put this in public domain. So let the whole world work on it so that we get to know what's happening exactly when a single injection of progesterone is given. At the end of it, if we are able to derive a saintly signature, if I may call that, a saintly signature out of it, can we induce that saintly signature in many other tumors? So that the next step would be to establish a similar kind of activity for other tumors, head and neck tumor being most common. There are gastrointestinal tumors that are being studied. There are esophageal and lung cancer being studied to a large extent on similar lines. So replicate these results at other sites with the same kind of technology. Finally, to have implementable, low cost and quick interventions which will have improvement in outcome. The aim of all this interaction is to have computational biology capability in India being evolved, and also formulate a bioinformatics group which is not just in India but transnationally. Training in general is another area where we could easily cooperate, and for that cooperation I feel that individuals who have finished their post-graduation or super specialty are about to get into their full-time staff positions could be exchanged between the two countries, and that kind of exchange I feel will produce a lot more interaction, a lot more novelty of thoughts. When two individuals come together from delivering the same kinds of goods but from different culture, a lot more novelty comes in because of the material on which we have worked, on which one has learned the medicine being very different. Insights are very, very different when you come to that kind of exchange. So it is this kind of exchange that I look forward to as part of cooperation. And to summarize, as I see that epidemiologically there can be lots of genetic, epigenetic and kind of studies which we could look at from the point of view of large number of young cancers, from the point of view of extreme low incidence of cancer in India. We could also look at larger biorepositories because of availability of large number of samples, and these biorepositories could be then utilized for various biomarker studies and common questions which are troubling US as well as India. Similarly, joint collaborations for newer technologies. That's one area where once a technology comes on the ground level, what can be done comes very quickly. That yes, this is feasible. I can have a high energy linear accelerator, even higher energy of linear accelerator coming in, and it can be utilized. It has the promise that it can probably give you a precision of delivery of care, and it will be adopted. But when will we test this? That is it required at all? Because the cost of this machine compared to the older machine is huge, and that cost difference we will not be able to offset till the time we prove that it is really effective. So testing technology is something that can be easily done in India, and we would be very happy to be part of studies that test technology so that appropriate technology is available at appropriate place, rather than a blunderbuss approach of newer technology being adopted because of the existing technology suffering from old age. Reinventing old drugs is an area which we are routinely doing. We just saw a simple injection of progesterone being reutilized for some other new indication in breast cancer. The presently approved indication of that progesterone injection is in threatened abortions, whereas we are utilizing it for breast cancer and shown that there is an improvement. Similarly, metformin, beta blockers, aspirin, there are so many very, very low cost molecules that can be tested in large trials. The trial that I mentioned just now of the perioperative window is something that could be tested for newer cancers before long-term adjuvant treatment is ever tested, so that we don't have to ever get on to 1 year, 5 years of treatment. A simple intervention preoperatively would help to a great extent. Finally, obesity is something that is troubling this country, that is troubling metropolitan India, and we need to find answers. It is best if we sit together, decide how best we can tackle this problem and intervene. Some intervention studies at the population level being done on either side would allow us a lot of good things. I'll not touch upon the rest of it now. The Capacity building for computational biology I have already mentioned. So finally, the threats. There aren't any threats, but there are some of them. What I mentioned just now to be tested are interventions which are very frugal, low cost. Industry may not be there to drive it, yet we need to drive it because they are in interest of public. IPR issues is another area which can trouble in sharing what we can do either side. But one thing is definitely certain, that creation of need is not healthy, and healthcare delivery systems essentially work towards their own irrelevance. As a person or as an individual, if I'm selling a car, a Toyota car or some car, I want everybody in my area to own my car. Whereas the end point of my intervention as a medical person is zero disease in society. If the society has a lot more diseased individuals, I would be a failure. So primarily we work towards our own irrelevance, and that's what we should be doing. Thank you very much.